I'm Jo Booth. I come from Glasgow Calzone University, where I am Professor of Rehabilitation Nursing. I'm just asking you to stand up because I work with a lot of people who are really, really interested in sedentary behaviour at the moment and the effects of sitting for too long. So you can sit down now again if you want, but I just always make people stand up just to sort of jiggle around a bit and help to prevent your the problems that come in association with sedentary behaviour. Okay, I think some of the work that I'm going to cover in this session is work that has already been covered by Jalet and by Doreen, so some of it will be a whistle stop. But I think we do want to make this interactive, and there will be lots and lots of opportunity for questions and discussion at the end. So please do join in as soon as I've whisked through this section. So just moving on from the pelvic floor muscles and the neurophysiology, we've got to get into the practice of bladder management. And the ICI, the last one that was published in 2013, talked about the fact that in neurogenic bladder management is primarily conservative. And really they listed three major elements of this, which was different forms of timed bladder emptying, whatever means that will take, controlling fluid intake, because obviously there's an element of what goes in comes out, and how that's managed can help the person to have an element of control, and also avoiding urinary tract infections. So there was no mention at all of self-management. However, if you think about it, everybody self-manages. 99.9% of the time people are self-managing. In fact, it's 99.999 recurring. People are self-managing their bladder dysfunction, whether it's neurogenic or not. It is the most common model of continence care, and it's something that we're only starting to recognise now as to how we can best support that. We know that less than half of people ever consult formal health services. We know that awareness and recognitions of symptoms is usually very, very poor. Many people, particularly as we age, people do not see issues with their bladder as representing a major problem very often, and very often people don't believe there's any treatment anyway. Now we know that there is, but this is the general perception, and many people will want to avoid bothering a doctor. Now if you've got a neurological condition, unless somebody actually specifically asks, or you've got a problem that really is severe enough to warrant mentioning it, many people won't discuss it at all. So there is an element of case seeking that needs to be included. There's usually a poor knowledge out there of the different options and where to seek help. And people are very frightened of treatment. Many people, because of the ignorance around what is available, will fear that they're going to come under the knife very quickly. And there is a great embarrassment, as we know, associated. So the upshot of all this is that bladder dysfunction is really seen as a condition more to be coped with and not cured. So if we're thinking about what self-management is, Doreen's already given you one definition. This is another definition that I just put up because I like it, because it's a very active definition. This definition by Levin sees self-management as a decision-making process. And it's a decision-making process by the person which involves them observing themselves. So they've got to get in tune with what's happening in their own body, and they've got to perceive that they're having symptoms. Now obviously for people with neurological bladder dysfunction, sometimes it's difficult for them to recognise and to perceive that they are actually having symptoms. So that's one of the elements that we can help them to identify. They perceive a symptom, but then they have to label it. They have to say, well, what is this actually? What is this? In self-managing, they need to judge the severity, and then they need to make decisions by assessing the different choices and treatment options that are available and what they're going to do. So a major part of self-management, which is coming to the fore more in the literature, is this idea of self-monitoring, because self-management is not a one-off thing, it's a long-term ad infinitum process. And so people need to learn to not only recognise their condition and recognise their symptoms, but then be able to monitor those over a period of time. So as Doreen said, self-management is not leaving the person, that's it, off you go, you're going to manage your condition from now on. It's about how we best support people to do this. In essence, it's an alternative to patient trial and error. Every patient will trial and error different approaches to managing their condition and to managing individual symptoms. And what we're trying to do is make this more structured, more programmed in how we go about doing this. So, as I say, they're helped to identify their problems, they're helped to make decisions and to set goals. I'm just looking at what's already been covered. So it's about increasing their awareness of physical symptoms and empowering people. And it depends really on this idea of developing self-efficacy and a belief in your ability to perform specific self-care activities and to produce the desired results. And I suppose, you know, one of the areas where that's very obvious in, for instance, use of intermittent catheterisation, where we know that if people don't have self-efficacy, if they don't believe that they're able to do it and they have the confidence to do it, then they won't do it. And so self-efficacy is something that, again, is gradually coming more to the fore in the work around supporting self-management. Oh, sorry. Okay, and it's very much a shared process. So talking about processes of self-management, there's a recent paper that was published by Shulman Green which really focused in on what processes are involved in a person self-managing. I think these really resonate very well. It wasn't specific to people with neurological conditions, it was self-managing chronic illness, but I think there's a good resonance here. The first process was really about this idea of focusing on your illness needs, and that the person who's going to self-manage needs to know about that illness, they need to learn about it, and they also need to take responsibility for dealing with the needs that they've identified. It's a new form of contracting really that we now have in healthcare, where it's much more a shared and collaborative approach to decision making. And this is new and it's quite scary for some people, both from the patient point of view and also from the healthcare professional's point of view. So focusing on those illness needs is one of the major processes. Also, as Doreen was saying, there are many resources out there, probably too many in some respects, that people can access. Many people are very IT savvy, and that proportion is increasing, as we know. I heard a figure that 73% of people in Canada make use of a smartphone. So there are many resources out there, but it's not just IT resources. It's resources which, you know, things like family support, people, there's an awful lot of decision making which is reliant on peer support. I know some of the work that I've done has, you know, it's talking to other people that has enabled people to make a decision, not anything that they've been given in a formal way. So resources are there, and that resource use is one of the processes that people engage with. And the third one, which is quite an interesting one I thought in this paper, was about living with chronic illness, actually accepting that it's there, and by processing the emotions that you have in relation to adjusting to the illness and finding a new normal. So recognising that you have changed and that you've adapted, and that will require practical lifestyle modifications and taking that responsibility for personal growth and satisfaction. Now, Doreen's already talked about the 6 self-management behaviours, but this is them encapsulated into quite a nice slide that Kara Tannenbaum put together and is published in the American Journal of Nursing paper that was referenced earlier on. And in essence, what you've got here is the situation where the patient, in a self-management model, the patient needs to identify the problem. If they don't identify that they've got a problem, then you may as well stop there. Following that, they then seek this evidence-based knowledge, and that evidence, you know, we might talk about it in terms of systematic review-based evidence, but evidence has a variety of formats, and from the patient's point of view, as I was saying, it may be talking to their neighbour, it may be seeking evidence from the internet, some of which, as we know, may be more or less reliable. But people will seek evidence to increase their knowledge. This is what they use to make the decisions. They will use all sorts of resources, the knowledge, and they will start to make decisions, and these decisions will turn into action plans. And this is a cyclical process. People will action plan continuously to based on feedback that they are getting through self-monitoring their condition. But the thing that's going to be very key to them actually enabling to go round this cycle is them developing their self-efficacy. And as that self-efficacy builds, and their confidence builds, and their feelings that they're actually able to successfully self-manage, then this process will continue, and you will have a person who's meeting their goals and is enabling the process to continue throughout their lifetime. So, Dorian has shown some of the self-management findings in relation to specific conditions. This is an overview of self-management in general in relation to urinary incontinence. It's not specifically those with neurogenic bladder or bowel dysfunction. But there is a very limited amount of information out there. It is increasing, but it's very small-scale studies, and generally speaking, they're not of high quality. But what they show overall is that when people are supported to self-manage, they can reduce their urine leakage, and they can reduce the episodes of urine leakage. They can improve their symptoms and their quality of life, reducing their symptom distress, and finding ways to initiate further self-treatment and help-seeking behaviour. So there is evidence, but it's small scale and it is just really starting to build. I'm not sure what's happening with regard to Canadian and the US and Australia and other countries with regard to supporting self-management, but there's a big focus on that in the UK at the moment through a body known as the Health Foundation, who are putting a lot of focus on supporting people to self-manage and how we best do that. So I do think it's something that's very topical. With regard to supporting self-management of neurogenic bladder dysfunction, there's lifestyle changes that we can support people to make, there's behavioural therapies we can support people to make. There's obviously pharmacological self-management, because at the end of the day, what people are prescribed, if they're not going to take it, if they're not going to adhere to what's been recommended, then that's a self-management choice in itself. And also electrical stimulation. So what I just wanted to do was to just talk very briefly about scheduled voiding, because coming from a nursing background, this is a big part of continence care, and particularly in people with neurogenic bladder dysfunction, you often find that different forms of voiding programs are a mainstay in treatment. And really, what I wanted to point out here was in terms of supporting self-management, a lot of what happens is this idea of timed voiding, taking people to the toilet on a regular basis, 2 or 3 hourly. But this involves passive patients, it's caregiver initiated, and this is not how you support people to self-manage. It's necessary for a lot of people because often it's the voiding program that's used in people who have cognitive impairment or very severe physical impairment. But what we need to be doing is really moving a little bit further up the scale, and we need to be going on to bladder training, which I'm going to talk a little bit about now. Just to say that the evidence for scheduled voiding programs is really fairly limited and very poor quality, so there isn't any real consensus with regard to choosing these. So bladder training is something that we need to know more about, really, because this is the kind of elements of bladder training that are commonly understood, which it's training behaviour to increase between void intervals and to increase a person's bladder capacity. There are elements that have been written about with bladder training, such as people understanding their bladder function through good education, urge suppression and urge control techniques that people can be taught, and also distraction exercises, which will help to control their urge and help them to avoid the need to go to the toilet. There's also approaches that have been described, such as preset voiding times, and the idea around bladder training is that the intervoid interval is progressively increased until it reaches a level that is a reasonable voiding interval for the individual. And these can be fixed or they can be responsive. And a key element of bladder training is that there is a degree of self-monitoring and feedback associated with it. So what evidence do we have around how effective bladder training is? It's a very safe way of dealing with bladder dysfunction. However, we haven't got any trials that investigate bladder training in people with neurological conditions. So we do need better evidence in that respect. There is the ICONS trial, which looked at stroke patients, did have a degree of bladder training in it, but that is the only one at the moment that has produced any evidence, and that was beyond bladder training. It was a more comprehensive programme. But there are 17 trials on bladder training in women, which doesn't include frail older people, and this is a total of 2,462 women. 6 of these trials provided no or minimal details about specific bladder training protocol used, so it's very difficult to really find out how best we can go about bladder training. Most of the trials are small and of really quite poor quality, providing minimal level 1 evidence that bladder training might be effective for women with urgency urinary incontinence, stress urinary incontinence and mixed urinary incontinence. But as I emphasised, there's really nothing around people with neurogenic bladder dysfunction. And there's really not enough evidence to determine if bladder training might be more effective than anticholinergics. So bladder training programs are very variable. They vary, and what we don't know really is what is the best way to go about bladder training with particular conditions. These slides are just really highlighting how variable things are. We don't know anything about the initial voiding intervals, because these vary between 30 minutes and 2 hours. We don't know anything about how the voiding intervals are adjusted. If you're bladder training somebody, you have people who would say, when I'm doing it, I tend to very kindly ask people to increase by 5 minutes at a time, sometimes 10 minutes, depending on the person, and that's around building their self-efficacy to begin with. But some people would say, oh no, if you can do it now, then you can wait another half hour, or you can wait another hour. And to somebody with severe urgency, that's really, really very difficult. So there's a lot that we don't know about the best way to approach this type of bladder training, and yet it is a mainstay of treatment. We don't know really about best goal setting and how that's best achieved. Different approaches to distraction and relaxation and urge control strategies are described, although not in any detail. This is something else that we need to do. We need more evidence around. And whether the use of the NAC is helpful in bladder training, although there does seem to be some indication that it is. We don't really know very much about the feedback. That sounds terrible. All I'm saying is we don't know very much about it, but there really isn't evidence out there at the moment. And particularly around things like the use of adjunctive fluid and caffeine adjustments, where the evidence again is very equivocal. Use of fluid restrictions. Commonly people do restrict fluid, but again it's not really very clear whether that's effective and for which patient population that might be the case. We know that it's very useful to tell people about constipation prevention and management, because we know that a loaded bowel can have a very adverse effect on people with neurogenic bladders. However, again, more could be done in that field. And we don't really know what the best length of bladder training programs are and how long they should be continued and what the sort of maintenance strategies are. So there's a lot we yet need to know about bladder training, and I just really wanted to point that out because it is so fundamental to what we do in continence promotion and bladder management. I'm just going to very briefly talk about transcutaneous posterior tibial nerve stimulation, because it's a fairly new approach to neuromodulation. We don't really know how it works. It's we think it modulates the sacral nerve plexus indirectly via the posterior tibial nerve, which is a mixed nerve branch of the sciatic nerve, and because this originates from the same spinal segments as the nerves which control the bladder and the pelvic floor, then this is a distant neuromodulation approach. It's thought to have its effect via the somatic afferent nerves, which modulate the efferent outflow to the detrusor and reduce the sensation of urgency and also the detrusor overactivity, but really the exact mechanism of this treatment is not yet fully understood, although there is some indication that urodynamically systometric capacity is increased, as well as aberrant detrusor contractions being reduced. Most of you hopefully will have seen the percutaneous posterior tibial nerve stimulation. Transcutaneous uses surface electrodes and has a much poorer evidence base because it's so new. At the moment there are 9 studies, small studies of variable quality. There's been 6 very small RCTs involving 202 adults, 183 of which are women with overactive bladder. And there have been 3 case series which involve 170 adults. 158 of those are neurogenic OAB, primarily related to multiple sclerosis. But when you put those together, what has been reported is a 48 to 68% reported cure or improvement. However, the improvement and the cure definitions do differ. Just for comparison, with the percutaneous route, using needles to access the posterior tibial nerve, there is a little bit more evidence that this is more effective, and it has been recommended by NICE in the UK for treatment of overactive bladder, as it is effective in the short and medium term. There are no safety concerns which are associated with the use of the, sorry, I've done that again, I'll keep putting the thing down, the percutaneous route. But it's a second line treatment because it tends to be used after conservative approaches have failed. It does require quite a significant time commitment by the patient, and there are quite major cost implications because it's about £500 or more per course of treatment because it's delivered in secondary care and it's delivered by specialist teams. So if we look at transcutaneous posterior tibial nerve stimulation, and I will get to the point here, this is in terms of supporting self-management, there are some indications that it may be effective for bladder dysfunction in small trials, and again there are no safety concerns. It's very, very safe. Because it's in effect TENS, you can't stimulate yourself to death with a TENS machine. So the idea is that it can be first-line treatment, and it can be an alternative to anticholinergic medication, which many people don't want to take because of side effects or for various reasons. Transcutaneous posterior tibial nerve stimulation, as it stands at the moment, if people are coming to clinic, yes, there is time commitment needed, but it can be something that the person can self-manage at home, they can self-treat at home. It's extremely low cost and it's extremely accessible. But we do need evidence of whether it's effective or not and in what applications. For instance, with regard to stroke, Parkinson's or MS. This is a picture of my leg showing the setup of the setup that we use. We use just a small stimulator. It's just a neurotrap that we use, but any stimulator can be used, providing it can be programmed. We apply 2 surface electrodes, one just behind the medial malleolus and one just slightly above that. We use a standard stimulation protocol with a fixed frequency of 10 Hz, plus with 200 microseconds, and a continuous mode of delivery. The intensity of the stimulation that's delivered is determined by the patient. We look for a hallux reaction, and then within that we encourage the patient to go above that level if they're comfortable doing it, or to just reduce to slightly below that. Most people manage quite happily to go above the level that the hallux is observed at, and the range of stimulation, it isn't really 1, but it ranges from 1 up to 90. So this is what we use. We use a treatment program of 12 sessions, and that can be delivered over a 6-week period or once a week over a weekly period. Going back to what we were saying about self-management, it is suitable for supported self-management, and it's an easy thing to introduce with people. You can demonstrate the use of the equipment with the first session, and I've not really had anybody so far who isn't able to easily use it. And this is enabling us to set goals and action planning. The patient can self-administer. They self-administer under using guidance and an element of supervision. This is demonstrating self-monitoring and feedback, that they're actually that they're self-monitoring their own reactions, and they're getting feedback from how they're using the equipment. Most equipment can be locked and has an automatic switch off, so it's really, really safe to use. And then what we do, and what I suggest, is that people are followed up at 1 or 2 weeks once they've started with telephone contact, which then enables us to promote adherence to the programme and increase their self-efficacy. Okay, so the results that we've got so far with regard to our clinics is that we've got an 85% success rate for people perceiving their condition to have improved or to be cured. And I was saying earlier that we've actually got 45% of the people who've been through the treatment programme have elected to then buy their own stimulators and to continue the treatment. The idea with this approach is that people will have, at the end of their treatment programme, they then have a period where they may be completely fine, they may have no more symptoms for a while, or some will require further top-ups. But because we know so little about it, we don't know what that duration is. So at the moment, people are coming back if they want top-ups, or they're buying stimulators themselves and self-treating. Okay, so what I thought, I was asked to put some case studies together, so I just thought I would very quickly tell you just about 2 or 3 of the people that we've treated as examples. This is Mr. Jackson. He's 83 and he's had Parkinson's since 2008. He lives at home with his wife, and he's got fairly limited outside mobility, but he can walk around the house with assistance. He's got very severe frequency, urgency, and his biggest problem, and the reason he came to us, was his nocturia 4 to 5 times nightly. He can only pass urine in a standing position, and he needs help to get out of bed. So basically, yes, we wanted to help him, but it's his wife more than anything, because she was exhausted getting up with him 4 or 5 times a night. So what did we do? Simple things in terms of supporting them to self-manage as a couple, talk them through it, gave them a standing frame and also a commode beside the bed, so that Mrs. Jackson can help Mr. Jackson out of bed and help him to pass urine in standing. But he tried TPTNS. He puts it on in the evening, or she puts it on, helps him to use it, and very quickly his nocturia has been reduced to once or twice nightly, and that's very, very manageable. It's very comfortable, very manageable, and they are continuing to keep Mr. Jackson in his home environment where he wants to be, and they were contemplating when they came to us him going into a care home. Here's another example. This is Miss Mawson. She's 31. She is a dance instructor. She's a ballet dancer. And she works with adolescents in community development in the north of Scotland. She travels around Scotland. She has a recent diagnosis of MS. In fact, her diagnosis came when she presented with urinary symptoms. Her urgency and frequency are so severe that she was just about to leave her job, which was really, really tragic, because she couldn't get through an hour's dance session without having to run to the toilet, and it was causing her severe embarrassment. So obviously we did the fluid management. We got her to stop drinking iron brew, which has huge amounts of caffeine in it. And also, although, as I say, I think the evidence is fairly equivocal in that respect. Anyway, her fluid management was altered, and she underwent some bladder training. But she, with TPTNS, she reduced her AUA symptom index from 16 to 6 during the treatment, and she is very happily still in her job, and she comes back and she tops up every few weeks with 1 or 2 sessions. That has been a real remarkable change for her, and she's very happy with the use of it. Finally, Mrs. Etheridge. Mrs. Etheridge is a lady who had a stroke in 2009, and she's a very interesting person because she came along having had continual problems with leakage since then. She has very severe fatigue, and she's got some memory loss. Her biggest problem is nocturia again. She says she gets up 10 to 15 times a night. I did find that quite hard to believe, and she wasn't able to do a bladder diary accurately. However, she spends a long time in bed. She goes to bed at 9 o'clock and she doesn't usually get up till about midday. So I don't know actually that the nocturia figures were accurate. However, with the TPTNS, she puts it on every single night. She puts it on at some point during the day, but usually in the early evening. And she is now at the stage where she's for many, many months now had nocturia 3 to 4 times in her period of being in bed. And she says that her first rise is between 4 and 5 hours after going to sleep. So she's very happy with that, and again wants to continue. So those are 3 examples of people where we seem to, the evidence is we need to develop far better evidence, but these are examples of where people really have felt that they've benefited. So, to conclude for me, I think self-management of neurogenic bladder is the most common form of bladder care. I think we've been able to demonstrate that, and that what we need to do is to support people to self-manage appropriately. This is key to ongoing success, but we really do need some good, robust evidence in order to understand how best we can do that. Thank you very much.
Jill, can you come forward to you for about 10 or 15 minutes just for any questions if you have any? Okay, just if you introduce yourself first.
Okay, I'm Audrey Melançon, physiotherapist here in Montreal. I have a question about the TENS. Do you use the TENS with a patient with loss of sensibility in their legs or impaired sensibility?
Yes. We like them to have some sensation, but it's very difficult because, and particularly say with someone with a stroke and a hemiplegia, we would usually use the non-hemi leg, but there isn't any real indication for us not using it. As I say, it's very safe, and particularly if they can give you some indication they can feel something. I think, I mean, the only reason we don't use it in people who have leg ulcers, obviously, and open wounds. We don't use it in people who are pregnant, although again, I don't really see any major reason why we shouldn't, but we don't use it in people with pregnancy, and we don't use it in people with epilepsy at the moment.
If I could just ask one question related to that is, what if the patient doesn't feel sensations? Would you even carry on?
I think probably no. Because, I mean, it is very safe, but I think if there was absolutely nothing, I think probably not.
That's a similar experience we offer for MS patients. Quite often there are issues with numbness, but it's a central cause. It's not like a peripheral neuropathy. So the tibial nerve, that stretch is intact, but it's because of the spinal cord lesion. And essentially we need to know if the tibial nerve is being stimulated or not, and hence hence I presume you increase your current strength accordingly. So the patient doesn't feel that pins and needles sensation. or it doesn't have that
anything. Sometimes
reaction.
they can feel something. I've had people say, you know, oh, it just feels a bit warmer, or, you know, you'll get something.
Yes, and that would tell us that the nerve is being stimulated. So there has to be some sensory response or a motor response, ideally. But either one, there should be some response that indicates the nerve is being stimulated.
It's even when somebody, one of the things sometimes you do get is people have quite severe edema, and then you have to increase the intensity dramatically to get anything. But I've never had anybody really have nothing. Usually you can increase and get something.
Hi, thank you for your wonderful presentation, all three of you, really, thank you very much. I was wondering if, so I use electric stimulation very much in my clinical practice. I just wanted to share that I also do transcutaneous sacral nerve stimulation on the sacral nerve roots as an alternative placement. So if the ankle doesn't, if the sensation's not intact down there. You know, I thought that the initial presentation where we were looking at the 3 different areas of where we need to consider what's happening neurologically was very helpful in that thought process. But what I was wondering is, can any of you tell us any more information about how to facilitate emptying in our patients with neurogenic bladder other than self-catheterization? Because some of these patients will void spontaneously. They will intermittently have increased post-void residuals, but not always. And so I find with some of the patients, for example, with MS, that we want to try to figure out ways for them to facilitate their emptying so that they can avoid the self-catheterizing if possible. The detrusor sphincter dyssynergia is a real bear because sometimes it happens and sometimes it doesn't. And so it's a tricky problem. So thank you.
Just about the stimulation of the sacral area. Quite a few years ago we got funding to use TENS for lower back pain in patients with MS, and their bladder symptoms improved. We weren't actually looking for that, but it was one of the qualified things that they said as well, so I think it does work. Looking at bladder emptying in a couple of studies I did when we were looking at pelvic floor muscle training and using intravaginal electrical stimulation and trying to train the contraction and the relaxation, so focusing on the biofeedback to try and get the muscles relaxed. It did improve their emptying, and we all, there are other techniques that you use as well. We can use, but there's no evidence really as well that it did seem to help with the emptying.
Can I just add to that we did a study a few years ago with frail older people in care homes with TPTNS, and the residual urine volume was significantly reduced in some people, and it was very, very small. There were only 15 patients using the treatment and 15 controls, but there were 5, I think, stroke patients, and they were the ones who the residual reduced. I don't know why, but it certainly seemed that it was something to do with the TPTNS. So I don't know if that's something for the future. And that would fit with what you were saying on intravaginal.
So there's been a single study that's come from the Netherlands. This is back in the early 2000s, which actually studied, I presume it was PTNS, it's percutaneous tubular stimulation, in young women with idiopathic urinary retention, and claimed that it improved the post-void residuals. But I'm going to say, in our department, we've tried it in a few women with Fowler syndrome or idiopathic urinary retention, and we didn't find any benefit. And probably that's, I don't know if other experiences have shared the experience of the researchers, the investigators in the Netherlands found, but obviously it wasn't replicated. And it's clearly not something that you would see in the list of treatment options for avoiding dysfunctional retention. But I think, identifying trigger techniques is something useful. And during your assessment, of course, if it's there, that'll be part of the program of self-management. Sometimes there is evidence for suprapubic vibration There's a buzzing device that you apply subcutaneously. In fact, what happened is a randomized control study that have actually shown that it helps the bladder emptying in men and women with multiple sclerosis. I think in practice, however, we haven't found it to be helpful in every patient, but I think patients who have a smallish bladder capacity that can be determined from the bladder diary and who have a spinal cord lesion like an MS, it's something worth a try, especially if the post-word residue is, just above the brim, that, and neither you or the patient are sort of convinced that intermittent self-catheterization is the way forward. And that's something that needs to be looked at. Other things I think would be sort of looking at constipation, mobility, for example, medications. So the patients might be on pain medications such as opiates, and if those are identified, of course, and if they can be sort of addressed, which many of these can be, then you'll find that the post-word residue actually improves. And perhaps the patient who's at, say, 150 mils or 200 mils, where you're seriously thinking about intermittent self-catheterization, you follow up the patient, you find that actually the post-word residue might actually come down.
Thank you.
Okay, Scott.
Yes, thanks very much. Actually, thank all of you for very interesting and helpful presentations. I've got a couple of quick questions for Dr. Panica and then a couple of comments to make. My first question is, you mentioned that in spinal cord damage that the afferents switch over from A delta to C fibers, is that right? So what is initiating the C fiber activity?
So actually in health, in all of us, we have in the afferent nerves from the bladder connecting to the spinal cord, there are two populations of nerves. You have the A delta and the C. And in infancy, it's the C fibers that drive the Victorian reflex. What happens is with maturation, what happens is that this C reflex mediated pathway, this bladder reflex pathway gets inhibited, and the A delta takes over, and it becomes, rather than a spinal bladder, it becomes a spinal reflex that controls the bladder. So the C fibers in health are actually dormant. So they're present, the C fibers are present, but it's dormant. Whenever there is an injury, such as say interstitial cystitis, for example, directly to the bladder, or a neurological injury, like spinal cord injury, what happens is these dormant C fibers now become active once again, and they then drive the overactive bladder in this group.
Are they also muscarinic? Are they initiated by the muscarinic receptors?
So they're essentially afferent pathways. But they are modulated by the vanilloid receptors, and hence in the previous studies that looked at, say, capsaicin, for example, or resveratrol was actually was based upon modulating this reflex pathway modulated the C.
The reason I'm asking the question is that if you instill antimuscarinics directly into the bladder in cord injured patients with high-level injuries, or indeed even in many people with MS, you can flatten their bladders very nicely. And that's clearly muscarinic initiated, if you like, an anti-muscarinic effect. So I'm intrigued by the switching and just wondered what was actually provoking it. The second thing, if I may make a couple of comments, because I think they are very important. When you offer your epidemiological data with the multiples of risk of renal failure, one has to bear in mind what's behind those data, because you're looking at a complication of pathophysiology, not pathophysiology itself. If you were to look at those people years ago, before we had treatments available for anything, right, the spinal cord injured with high-level injuries quite likely had a very high incidence of renal failure and indeed death. I would suggest that 5 times the general population is an estimate based on the fact that that particular study was done from a spinal unit, right? And the study where that came out is a few decades old. It's very interesting, but management has moved on, so the effects in good management should be much lower. And the important point is it is a complication, so it's crucial that we don't lose sight of the fact that poor management would produce a much higher risk. So that's certainly the case in spinal cord injury. The MS story is equally challenging, because if you get behind the data that was produced partly from the Queen Square study back 20 odd years ago, that was not based purely on looking at pathophysiology. That was actually emanating from a unit where people were immensely aware of people with MS, and the mere fact they were recruiting people from a study or from a group that were being managed. So the difference between what you select in Queen Square for that kind of data is very different from what was happening outside. And at that particular time, forgive me, this is a bit of history, right? People with MS typically, even at that time, were treated very badly. And they were ignored. People were telling them, "You got MS, go away, there's nothing I can do about it." Okay. But also, right, the symptoms that people present with renal failure are very similar to the symptoms that people present with
Sorry,
multiple
Scott.
sclerosis.
Sorry, Scott. I've been asked that we have to close this session because there's a
Okay,
lot of people.
I'll just close.
We can go on the discussion.
I'm happy to do that.
Yes, right,
Just
yeah.
to finish this. The important thing about that is that the investigation of people with multiple sclerosis in regards to renal failure was almost non-existent. So my suspicion is very high that we were missing renal failure in people with MS.
Thank you for that.
Okay. So thank you very much for coming. Thank you.